Okay, ladies and gentlemen, and let's start the second session in the morning. And because of later, the Professor Tan will rush back to Taipei for the airplane. So we would like to invite Professor Tan first to give us a talk. 导播，先让我们这边先讲个
不是
talk 好了，然后麻烦跟那个导管师讲一下，我们这边先讲一下，
Yeah.
因为谭教授等一下要赶飞机。
Okay. I do apologize for making such a rush, but here's my presentations. So I was given the topic of talking about femoral popliteal CTO complication, but I thought angioplasty complication is quite universal, so I changed this topic to just PTA complication from the angioplasty. So I have no conflict of interest. So in the following 5 to 10 minutes, I will briefly discuss about some of these aspects of complications, such as dissection, acute vessel closure, perforation, thrombosis, and embolisms. So for dissection, I won't, strictly speaking, this is not a angioplasty complication because vessel dissection is what we hope to achieve with balloon angioplasty. But of course, controlled dissection is more important than all this diffuse spiral dissection. And with adjuvant thrombectomy devices, such as what we've seen in the past few days with a Jetstream or Hawk or a shockwave balloon, hopefully this dissection can be controlled and be managed with just balloon tamponade. But in case the dissection is very diffuse and flow limiting, or most of the cases, we can handle that with a stent implantation. And for dissection, a lot of the time, you can't really appreciate the extent of dissection with a single plane. For example, on the B image, it looks okay on a single AP projection, but if you tube the angio to another angle, you can see the dissection actually comes mostly in the posterior vessel wall. In those cases, a lot of the time we have to tack it with a metal scaffold. Of course, those are dissection from angioplasty. In some cases, if the dissection is non-communicating, such as this case of a wire getting into the subintimal place and causing a non-communicating dissection and hematoma, causing acute vessel closure. In those cases, probably we'll need to open up the dissection plane to release the hematoma and the compression. In these cases, we'll check it with IVUS, confirming that there is a hematoma at the compression site. And then in these cases, we actually use a cutting balloon to open up the distal part to release the hematoma and subsequently restoring the flow. This is, not the usual case we've seen during our angioplasty, but it can happen if our wire go inevitably into the subintimal place and could not pass out through. Now, perforations, most of the time you have to really recognize this complication early on because this can be disastrous, especially if it happens in the iliac region. Could you click on the video? Yes, click on both, please. So this can be disastrous if not recognized early, especially if it happens in the iliac region, because those are cases can have disastrous outcomes. The patient can bleed quite extensively before you realize before the BP dropped. And most of these cases, bare metal stent is probably not enough to seal off the perforation. And a lot of these cases, balloon tamponade, and enough of the time, you would need a cover stent to patch up whatever perforation it is in the iliac region. Similarly, for the femoral region as well, and the risk for femoral artery perforation will include very calcified vessels, such as in this case, overdilation, and also use of atherectomy devices. Now, this is a case of a distal femoral very calcified lesion you can see. Prepping the lesion is not difficult with balloon angioplasty, but with a very suboptimal result. So in this case, we opted to further predilate this lesion with a slightly oversized 7.0 vessel in a 6-point-ish vessel. And you can see the balloons with the 7.0 balloon opened. quite well, but the problem comes after, because after we deflate the balloon, the patient start complaining of pain. So this is one of the signs that the vessel is injured after the balloon angioplasty. So usually, if the patient complains of pain during balloon inflation, is quite expected because you are stretching the artery. But if the patient complains of pain after balloon in deflation, then that's the time that you really should suspect there's some injury to the artery. Now, in this case, of course, right after the patient complained of pain, we did angio and show there's quite diffuse, extensive perforation at the balloon site. The immediate thing to do is to recognize this complication and tamponade the lesions. Now, of course, it will be very cumbersome to exchange a 7 to a 6 millimeter because it's a 6 millimeter artery. So immediately we just blow up the 6.0 balloons at a very low pressure, while we prepped up the 6 millimeter balloon. And then we exchange it very quickly, while at the same time applying external compression on the perforation side to stop the bleeding. And then we tamponade further with the 6.0 balloon at the perforation site. And very importantly, for femoral artery and for all other perforation, you need to check if the balloon tamponade is actually sealing off the perforation site. So in this case, could you click on the video, please? The last two. Oh, no. Yes, you need to check if the balloon tamponade is effective to seal off the perforation. So we need to check the proximal by doing contrast injection through the sheath, and also distally by doing contrast injection through the balloon catheter. Because sometimes, especially the perforation site, if it's very extensive and big, the balloon length might not be long enough to cover the entire perforation. So you need to check both the proximal and distal to make sure the perforation is sealed off by the balloon tamponade. And because you can see this is a fairly big defect on the vessel from the balloon angioplasty. So in these cases, actually the perforation was not sealed off with just simple prolonged balloon tamponade, and at the end we have to place a Vibrance stent to seal off the perforation. Could you click on the video, please? And this is after the placement of the Vibrant 7 times 100 stent. Of course, you can argue that you might actually need a bigger stent because this looks like a 6.5-ish vessel, but I think the key there is just to rescue the patient and seal off the perforation, which is more important than achieving an excellent angiographic result. And in other cases, perforation might not need a lot of attention. So in a lot of the cases, for minor perforation, such as these AV fistula cases, then those cases, the perforation tends to be small and will not cause a lot of complications. Thrombosis is another issue that we need to consider, especially if the patient has pre-existing vascular disease. And the clinical presentation is usually similar to acute limb ischemia, pale, pallor, paresthesia, etc. In this case, just showing a patient presenting after a PCI procedure from the left groin with a pain on the left side, and you can see some mottling appearance or reticularis appearance of the left leg, suggesting of a acute ischemia. In those cases, of course, you can diagnose it in the timely fashion. You can institute treatment. You can do surgical thrombectomy or endovascular thrombectomy. Now, for this case, it's a iliac artery thrombosis. So we opted to do an endovascular procedure with an angiojet to clear most of the thrombus. And because most of these cases actually happen when there is pre-existing vascular stenosis. So in this case, we simply tack up some of the iliac stenosis with a stent. And the patient's leg actually recover fairly well after the thrombectomy procedure. You can see the color actually comes back quite nicely. Now, embolization is another difficult thing to treat, especially if the embolization happens in the very distal artery or the capillary. The common presentation would be gangrenous toe, blue toe, pain. In some cases, if the embolization happens to the kidney or in the brain, you will have end organ failure, such as renal failure or stroke. The treatment, most of the time, if it's a very distal embolization, such as in this case, a digital embolization, a lot of the time you can't actually do anything about it except for conservative treatment and anticoagulation. But in other cases, if the embolization happens in the major artery, such as in this case, which is embolization of the distal popliteal artery after a thrombectomy procedure, then you would consider embolectomy. So in the past, of course, you can ask a surgeon to do a Fogarty embolectomy, but in this case, we can simply use our suction catheter to aspirate some of this embolytic material out. In this case, we use the Penumbra thrombectomy catheter, which is a aspiration catheter. You can see some of the material that we can aspirate out from that embolic lesions. And then after the embolectomy procedure, you can see the flow actually restore quite well afterwards. Now, this is another case of an unusual embolization event. So this is a patient with a occlusion of the entire right iliac artery. So getting the wire across is not difficult, which is not a very good sign, as you will see, because in those chronic cases, you will see calcified iliac occlusion, and those chronic occlusion tend to be pretty stable and will not move. In this case, however, because the occlusion is fairly fresh, it's very soft thrombotic material. So after balloon angioplasty, you can see there is actually the thrombus actually was squeezed up to the distal aortic area, distal aortic bifurcations, and impending to migrate to the contralateral side. So now, traditionally, this you would need to ask the surgeon to do either aortic cross clamping and bypass. But in this case, we opted to use a kissing balloon trapping of the thrombus. As in this case, you can see the thrombus was trapped in the distal aortic area and was not mobile anymore. So another kind of complication you need to look out for is some of the complication specific to some of the devices, such as in the directional atherectomy devices for this very eccentric calcium nodule at the common femoral artery. So traditionally, of course, these cases should always be considered surgical endarterectomy of the common femoral artery, and patch repair would be probably a better option if the patient agree and also the surgical risk is acceptable. But in this case, because I think the patient has a very poor cardiovascular reserve, so we opted to do endovascular thrombectomy of that calcium nodule at the common femoral site. So after the directional thrombectomy, you can see there is some aneurysmal formation at the common femoral artery. So we thought that that might actually seal off with a bare metal stent, but actually most of this aneurysmal formation is almost equals to a perforation, a concealed perforation at the common femoral artery. So in this case, actually it doesn't really help with just the implantation of bare metal stent. So at the end, we have to put in a cover stent across at the common femoral artery. And ultrasound also shows that there is actually a concealed perforation with quite a big sac of aneurysmal sac around the common femoral area. So I think in conclusion, handling complication in the peripheral angioplasty, the first and most important thing is to recognize the presence of complication. In time, a lot of the time, timing is the essence. You need to recognize the complication in the timely fashion, especially in case of a perforation or embolization, where time is the essence to save the complications. And you have to recognize in some patients, some of the risk factors will predispose them for a high risk of complications such as calcified vessel, female gender, very extensive PVD, and also use of any of those adjuvant thrombectomy devices, atherectomy devices. And once you recognize the complication, the next thing is to take action. So for most of the perforation cases, then balloon tamponade is probably the immediate action you can take to stop the bleeding from the perforation site. And while the balloon is up, while you are putting the device up, then you can think about what will be the solution to treat the complication, whether you need a cover stent, whether the lesion itself is not at the bifurcation and suitable for cover stenting, or whether it's a terminal artery, which you can deploy coil embolization of the perforations. And if you are deciding to use cover stent, whether the wire that you're using is compatible, whether you need to upsize the sheath, all these things you need to go through your mind while the balloon tamponade is taking actions. And last but not the least, you always need to have a backup plan. What if the first solution fails? What will be a backup plan be? And my backup plan is always my good friend surgeon, because they can do amazing things with the artery. So for common femoral perforation, they can simply patch up the defects, and for embolization, they can do open embolectomy, which is just as effective as the aspiration thrombectomy procedure. And my next best friend is, of course, the cover stent and coil. So these are some of the devices that you always have available on shelf in the lab, just in case some of these major complication happens. So thank you. That's my talk.
Any question? Okay.
Okay, because of time limiting, so one question. Is there any
Yes,
question
please.
from the audience or panelists?
Okay.
Okay, thank you, Professor Tan.
All right.
Thank you.
Thank you very much.
Thank you.
The room 1 is waiting for us. Let's connect to the room 1. Hi, we can hear you.
Room two. Room two.
Okay, here's the room 2. Room 2 at first.
艾宾奇这个画一下
Hi, Dr. Zhang. Do you hear us?
Hi.
Hi.
Yes. Hi, Soga Sensei.
Oh, good to see you again. Could you show
Good
us
to see you again.
Yeah, presentation?
Yeah. Yes, let me introduce. This is Dr. Yan with me, and Dr. Yan will introduce the history of the patient. Okay, this young female here, the history of pulmonary embolism. This May, and right now he under the DOAC therapy for the thrombotic prevention, and from the venography of the lower extremity, we note there is a feeding defect over the left side iliac vein. So today we come to do the procedure to run the IVUS to measure the stenosis and evaluate the rule of stenting. Thank you. Yes, and let's see the venography we just did. The venography. 也可以 play 那个像那个第一组。Okay, so you see the venography.
Yes.
Okay, yeah. So the first shot, Dr. Yan with me, we're also shocked with this image because it looks very good. Nothing happened, just some collaterals. Yeah, but now we can see the IVUS. We switch to IVUS. We can play the real-time IVUS. Okay, now we pull back. Okay, here is a stenosis.
Wow. This is the value of IVUS.
Here is the this is the iliac vein. Yeah. Okay. So can we play the IVUS?
Okay, this is the 035 IVUS.
Yeah, 035 system.
IVC, and we can see the compression here. There's a very severe compression here.
Where is the tight
Okay.
stenosis?
Yeah.
Yes.
Where is the
So
tight
this is
stenosis? Could you locate the stenosis in over the venography? Yeah, where is the most tightest compressed area?
play 杠那个 venography 的地方。
Yes, as we know,
第一个
the planned
那
venography can
看一下
miss
最
up
最狭
to
的地方，把它停下来，
25% of iliac vein lesion.
重新再拉一组嘛。然后你现在就最窄的地方停下来就知道了。
好了，来我们再拉一组哦。
Show us the angle.
Okay, pull back.
Okay.
Okay, it's here.
Okay. Oh,
Here
here,
is
just
the
the
tight
ostium,
stenosis.
the common iliac vein. Yeah.
Okay.
Yes.
Yeah. And we
pull
can
back,
see the venography. Yes.
Go on,
Yeah.
pull back,
Mhm.
and
Yeah. And we see the venography now.
yeah,
Mhm.
pancaking.
Yeah, just the
And
ostium
constaining.
of the the ostium of the iliac vein.
Yes, I think the contrast thinning may be mixed by the intestinal air, so we cannot very clear to identify the contrast thinning over there.
In this case, I think there is collateral to the prelumbar and the prevertebral drainage vein, and there is a reverse flow to the internal iliac. So I think it is a stenosis over the common iliac vein. It's very typical non-thrombotic Mason syndrome.
Yeah, this is maybe the hint. How do you think about Dr. Tan?
Thanks very much. This is a very interesting case because I know the patient had a previous deep vein thrombosis as well. And if you look at the IVUS as well, as you go through, there are actually some evidence of webs or the white debris that's sitting inside the vein. So could that be previous scarring or actually just come from the compression effect? It looks very focal, that lesion, actually. Are there any other compression points lower down on the IVUS? I don't see anything on the other points.
No.
But it's just that
No,
point
no.
which is in.
Just focal stenosis.
Can I ask you, the indication for treatment is just left leg swelling, is that correct? There's no
no
wounds,
leg
there's
swelling.
no venous ulcers or
No,
symptoms?
no.
It's just swelling, is it?
Mild swelling. Actually,
Has the varicose veins or the CVI, the GSV or the SSV reflux been treated already before we go to this?
no.
Okay. So what's your plan at the moment for
So-
this?
I think two plans. One is POVA only, and the other one is stenting. And the third one, I think, go on DOAC therapy, but possible long time because the risk of recurrent thrombosis.
Do you really think POBAR is going to work in this kind of scenario because of the pathology here? It's a compression effect. So,
Yeah, I agree.
do you have you don't have the radial force to keep it open because the recoil is very significant?
Yes, so in my thinking, I think short stenting is reasonable.
Yeah.
And
But
common.
But short stent bear the risk of migration, especially when the stent length shorter than 6 millimeter and the diameter lower than 14 millimeter.
Hello, Dr. Chang. If
Yes.
no IVUS available, can you check the pressure gradient between the IVC to the common femoral vein? If no IVUS
if there is
available,
no IVUS, this is the only thing we can do. But sometimes it's because this is venous system, the pressure gradient might not so obviously Yeah, so that's why we need IVUS, I think. Okay.
Can I just address that
So,
issue about
should
the
we do-
pressure effect across when you're measuring pressure effects across a lesion and venous? Actually, you actually underestimate it when the patient is lying down, actually, because actually they're not that great. It's also very variable. Also, this is not the physiological position of the patient, because normally we're standing up, aren't we? And I think that can be very misleading sometimes. So I've stopped doing pressure measurements across a stenosis as well because of that fact.
Okay.
Okay.
Sometimes
So
I
should we
prefer
try
to.
POBA first?
Sometimes you can measure the stenosis rate, especially with reverse Trendelenburg position to increase venous pressure. That will highlight the stenosis compress created by the compression.
pressure kit， 能拆个 pressure kit， 要量 pressure。
真的要量啊？比如说那个躺着量也不准
啊？
躺着量也不准。
哎，建华，谢谢你们这边先继续进行，我们转换到另外一间，好不好
OK.
We shift to another room one. Okay.
Michael the introducer. Michael. Okay.
Good morning.
过来了。Good morning, Dr. Sun.
Yeah, we are
Sun.
here.
Good morning.
So can you give us a short illustration or demo to show us about the history of this patient?
Okay. Good morning, everyone. I'm John from Kaohsiung Changge Memorial Hospital. Dr. Sun, Dr. Sok, and panelists. Good morning. I introduce my assistant first. Dr. Huang and Dr. Lin, a very young staff. And the case is a 60-year male and has history of diabetes, hypertension, CAD. 6 months ago, PCI done for him first, and 3 months ago, we performed the right femoral popliteal, CTO, and DS first. And till now, he still has symptom of claudication. Should be RAS for 4, 3 to 4. And so we can see the angel first.
Okay.
Today our
thank you.
target is a left femoral pop. Yeah. Okay. This is our approach right femoral artery. Because this is bilateral CTO, so initially I see the SF jump size maybe below the femoral head initially, 3 months ago. And after the canalization, we put BS. And below knee is a set of...
The flow is quite good.
Yeah. Wait. Yeah. Okay, then we treat the left first. We can see some lesion in the medial artery. However, we measure the pressure gradient between the lesion before this EVT. It doesn't have a significant pressure gradient. So we direct enter the left common femoral artery. However, depends on the right EVT result. I have no idea which one is the inlet of OCSFA. Because we have see some stump here, very short, maybe 5 millimeters.
So Professor Soka says, can you give us some tips how to find the ocean?
More left oblique, that change the angulation. So if impossible, it's difficult to identify the osteo. Maybe I use the IVUS.
Yeah, I agree.
Hi,
but you can see, yeah.
Yeah, this
Sorry.
is Junu Kim from South Korea. The thing I use often is also just EVUS, because in the left groin, it's very easy to see the stump of the SFA. So you can place the ultrasound over the left groin and put a marker on the osteum and then identify on the X-ray so that we can identify if what we see on the angiogram now, if that is the stump or not. We can correlate with the ultrasound images.
Yes, totally agree. Sometimes we will
Yeah.
forget our old friend, EVUS. Yeah, this can help us very easily.
Yeah, I think EVUS is very useful in this case, but I think I'm not the expert for the EVUS, so I need to depend on my familiar procedure. So I perform echo before the procedure. So I see the maybe small stump, maybe location around here, but I still cannot confirm because I didn't check angio and the echo spontaneously. So, but depends on the angiogram. The CTO body seems not so long. Yeah, the body only proximal to ostium. So initially, I decided direct retro because the below knee blow is also acceptable. Yeah.
Yeah,
So
seems to be
we
acceptable.
punch. Yeah. And then I sometimes in such case I will advance my guiding catheter past the potential ostium to the far distal injection to find out the ostium, because if we use the contrast from the higher than the ostium, sometimes the flow is too fast. And then if we distal use a retrograde flow, might be slow flow will enter the ostium. And after the 2 injection and the checks, yeah. And so I think it might be the possible inlet. I mean the initial tip, even though the level is different between the 2 low limb. So I retrograde initially with from distal femoral puncture and B18 advanced CTO stump, distal stump, and use the this is a little loop because initially I hope to intraplate advancing. However, there's some resistance, but when the resistance occur, my wire passed. So I tried to change to Traeger 12, but it still doesn't work, and it goes outside the common femoral artery, and then we tried again from ostium at the anti-grade approach. And with that, I tried my wire in the still there. And anti-grade wire, we use the either use a Gravius 01A or Astado 2040 there to recanalize, has some distance between the lesion. So we change again, we retro puncture again with Astado 40. And then we check the different angle. I think the distance is more short between NT and the retrograde roots. and then we try to bed it. Yeah, I think it's very short. So we keep the integral CXI as a guide and parallelly retrograde with the Astado 40.
So,
And
Dr. Zong,
yeah.
which is the best place for you to create a connection between two wires, more proximal to the ostium, or
Yeah. When we puncture, it passes to the true lumen, and externalization.
Oh, yeah, congratulations.
Yeah, direct enter
Too fast.
Guiding catch. Yeah. I think it's very fortunate, and I also remember in Kokra, I always keep three S rule, right? So that's what I say. Speed, safe, and simple.
You're right. You're right.
Yeah,
Makes sense.
Yeah. So So I think it's very fortunate we enter, and we will perform the predilation of proximal part to confirm we are in the extraplate or intraplate.
Okay, so please go ahead, and maybe we can move to another room. Okay, congratulations.
Thank you.
Yeah.
Oh,
Okay, room 2, Dr. Yan and Dr. Zhang, we are back again.
Yes. Yeah, we just do POBA. Yeah, we use 40 millimeter balloon and do POBA first. Yes. Yeah. So can you show the IVUS after we POBA?
Yes, there is still a lot of collaterals.
Yes, but you can see that this is IVC. Okay, please play. Okay, this is IVC. And once the very tight lesion, not so tight, but there are still some outer compression here.
Can I just ask the panel actually? How long would you POBAR pre-dilatation for in the venous system? Because no one really knows actually, and does it actually make a difference? 1 minute, 2 minutes, 3 minutes? I'm a 3-minute guy, like with my arteries, but I know in Japan they do 5 minutes sometimes as well and give some heparin on table. So it'd be nice to hear what you guys think.
Good question. I'm not patient. Maybe 3 seconds.
I'll go for 5 seconds. Yeah. I think it's because we're not relying on the balloon to remodel the vessel like in the arteries. We're trying to avoid dissection and stenting.
Absolutely.
Here, the primary goal is to do primary stenting. So
I just think that if you pre-model it with the artery, the stent will fit better, and then when you're right near the bifurcation, it doesn't jump as much as well. The stent. That's my only thinking on why you would do it a bit longer.
Yeah, for me the same. If for MTS, I will quickly move to stenting. But for the PTS, sometimes we will do the venography to check is there any extravasation. Yeah.
Okay, 这边可以。
找一下。
进去一点点而已。哦，开了。
这样子开了。
可以，这样可以。
Show us the angio.
导播帮我们看。So
okay.
already deployed the venous stent. Could you tell me what is the spec of the stent?
Oui. Okay, this is Venovo stent.
What's the size?
We choose
20.
14.
14.
14.
Okay.
14, 60.
Do you think that's long enough, that stent? Are you going to leave that stent and that at that posture because it's in a very
correct
obtuse
position.
angle?
Good position.
correct 杠，
你知道吗？
correct 走不
对啊
见了，，
好了
This
可以
collateral disappear. Congratulations.
，Yeah.
Yeah.
Mhm.
So do
Okay.
you do the
So,
post-dilate?
After this, yeah, do you do post dilate?
I was again post dilate 16，这14不刚才是把它
So, guys, how far do you leave the stent for those who are just starting out their venous stenting adventure? And just as a teaching point, when you've got a May-Thurner syndrome, how far do you place the stent inside the IVC? Because you've got to cover the lesion, otherwise you get a watermelon seeding effect. But how far do you deploy in to make it sure that it doesn't come back at yourself? What do you guys think?
How do you think, Dr. Zhang or Dr. Yan? Yeah.
In this case, I just deploy and see the flare of the stent, and then I pull back a little bit, and if I feel some resistance, and then I deploy the rest balloon.
Yeah.
Stent.
For me, I will 5 millimeter longer than the lesion. But last time we have a collaboration with my good friend Human Jaleh with the lab demonstration for 5 venous stenting cases. He suggests me to only 2 millimeter longer, approximately. Yeah, especially for Venovo because they have the flare.
They got
Yeah.
3 millimeter flare at the end of the
Yeah.
stems. Yeah. Can I just ask, do you feel that's a long enough stent for the lesion? Would you leave it like that, or would you take the stent lower down into the straight portion because of the risk of it pushing up? It's a very short stent. Is there any, is there any thoughts about extending that stent into the what we call the
Yeah.
black zone, basically the steep
Yeah.
black zones, basically straight down, basically. Otherwise, the risk of that pushing up,
Yes,
basically,
yes.
and
Always
flying
hold
off.
the
Yeah.
balloon during post-dilate.
Yeah.
And for longer stent, I prefer do the distal ballooning to anchor the stent first, avoid
可以
migration.
哦，来 pull back，
All right.
Oh good，
Do you think roundness of the venous stent is very important or just not a very important issue? Roundness of a stent after stenting.
Okay.
Because sometimes the stent may be oval, not so round.
结束了
I。think that's where your post dilatation comes into play. I think you do need it a bit
So the
more.
final injury.
They are compressed in different regions, like at the ileo cave, ileo.
Okay.
Iliofemoral junction and also the
结束，
ilio where the confluences, ilio confluences as well, they do get compressed. So you need to make sure that they are fully. So that's why I do IVUS measurements pre and post stenting to see if there's a big effect. So yeah,
要用下
I think that's quite important.
Yeah.
Whether the flow is very important. It's not the same as arterial here. You want a big enough area.
Yes, good job, Dr. Zhang and Dr.
拉
Yan.
个沙大概要1个小时。
Can you
Yes.
show me the final IVUS and the final venography?
Yes. Let's see the final IVUS. Yeah. Okay. This is IVC, and we took the stage just at the ostium of the iliac vein.
Be good. Roundness of stent
Yeah.
seems to be good.
Okay.
And the vein
Yeah.
distal to the stent collapse without collateral. Good. And the
Yeah.
how
and,
about the venography?
Yeah. This is the final. Yeah. You can see the final venography just up the upside of the IVUS. That's the final angel. Yes.
Yes. Is there any question or comment from the panelists?
I want to ask, what kind of antiplatelet or anticoagulant for this patient? How long for this patient?
And because this patient just had pulmonary embolism, yeah. So now she received NOAC's treatment, and the pulmonary embolism happened when she was pregnant. Yeah. So I think 6 months is at least period we need to treat. And after that, I think we can discontinue the the NOACs.
Yes, about this issue, according to the recent report by Human Jaleh in this symposium just last month in New York, he just published a meta-analysis in European that shows their data for MTS, they prefer DOAC single for 6 months. And for the PTS, they prefer the DOAC for 1 year. And the follow-up by maybe ivosartanography or CT venography. If the lumen in the patency is quite good, they can stop the medication. Yes, for PTS, 6 months for the MTS. Yeah.
Yeah, thank you. If you read the Delphi consensus, there was a big survey done around the world actually about what different venous surgeons would do. The consensus isn't there basically. It's completely random what they would do. And I mean, for me, myself, I mean, for PTS, I would definitely go more than 1 year, which is in agreement with what he said. For compression syndromes, I would give them 6 months to allow endothelialization of the stent. But I actually would add in an antiplatelet agent as well, because it works differently, especially if you're going to get thrombus early, especially in the PTS patients or post-DVT patients that you're stenting.
Is that a single platelet or dual antiplatelet? How long? It's just a single lifelong?
No, I'll do a 3-month period.
For double? I said for single, okay.
For PTS, for compression syndromes, if after 6 months everything looks good on the duplex, I do duplex because my sonographer can do that, I would just convert them to a single antiplatelet agent actually. And I think that's due. And you look at the 3-year data and 5-year data from Venova. I mean, we have 3- and 5-year data from using the Venova device. There are very few occlusions. Yeah.
Okay, is there any other commentation or question from the audience? Okay, everyone think you are perfect. So please lend me your hands to give a big applause to Dr. Zhang and Dr. Yan again. Thank you very much. And let's move back to room 1. And Dr. Zhang can prepare the next speech. Okay, we are back. Dr. Zhong, how about?
I think fortunate is always fortunate, but the real world is always very crucial.
Yeah, will preparation brings the fortune. Yeah, you are always well prepared.
Fortunate soon, but the engine might be in the sub. So I want to ask panelists and moderator, how about your idea or your suggestion? Do you suggest me to integrate the re-entry or I would guide the re-entry to treatment or just stop here?
Dr. Zhong, so already guide wire is crossing. You should proceed your procedure, the balloon angioplasty. You check the iris something, then the guide wire is passing the subintima, right? But maybe you should put the stent for the proximal to keep the patency. So also iris tells us the vessel diameter is much bigger, 7 or 7.5, nearly 8. It's a very discussable point.
Yes, I think you can be brave. Although even the wire is not totally true lumen, but I think it is above the EEN. So I think it's safe for you to do ballooning.
Yeah, I also think so because I think there might be outcome in a true lumen or in a sub might be not so different to achieve enough MRA, maybe also have a good outcome and to shorten the procedure time. Yeah.
Any thoughts about? Can I just ask, is there any thoughts about using a a thrombectomy device or a atherectomy device in a CTO, a long CTO flush occlusion here, because your patency rates are going to be quite small if you're not going to stent here at the proximal region.
But the guide wire is passing the subintimal.
Yeah.
Yeah,
No,
but
just
maybe
the profile.
atherectomy device is not so work
好
well.
像大
I
家
think.
有没有特别要？那就一个6的法论。
What is your preferred Soga sensor to how to manage the ostium lesion here?
Well, maybe put a stent.
对对6的讲。
A short stent or
To cover the whole
lesion.
CTO lesion.
Okay.
So this is a moderate stenosis or severe stenosis. Maybe I treated with a DCB or something, but for the proximal, I need a scaffolding.
Yeah. So how to locate the proximal edge of the stent to avoid the gelling of the deep femoral vein or just
Yeah, actually, I started thinking after the balloon angioplasty. Yeah, which is
肌
osteo.
肉最长的。
A little bit the guide wire enter into the subintimal, then go back to the true lumen and the common femoral artery.
I think one thing I would like to ask panel is you can see the ostium is very proximal and we've come through the subintimal at near the ostium. So if we place the stent to cover the ostium, it's probably most likely to cover the deep and profunda in this case, in this patient. So in that case, would you be comfortable to stent over the profunda in this kind of case? Or so let's say after your suggestion of doing the POVA first, and then you decide you want to put the stent, and it's inevitable that you have to place it to cover a little bit of the profunda or most of it. Would you be happy to go ahead, or would you start wiring again and doing something else?
For me, I think that ostium deep femoral vein is a sanctuary. We never jeopardize them. So I don't know how about the Soga sensei's opinion.
I'm asking in this patient because you can see the ostium is very close with the profunda arising on the other side. So you can see for this patient,
I
Yeah,
prefer
yeah.
ballooning first.
ballooning first. And
As a surgeon, you never want to cover the origin of that profunda. You lose your profunda, you lose your leg if that SFA goes down. So no, I wouldn't touch it. I wouldn't go near it with a stent.
I think it's something that we will observe later on in this patient after we balloon it. And then, yeah.
So Dr. Zhong, you want to balloon first?
Yeah, balloon first and consider
Yeah,
proximal
retrogradely.
stenting antegradally, predilation retrogradally, and depends on angel, and put the proximal BS and this DCB at the mid to distal SFA.
Okay. What is the size of balloon?
Now we open with 6 millimeter first, and
Which brand?
deploy yeah, this
What
one
balloon?
is Sterling
Okay.
6 by 20 first.
Ask the panel, what do you guys think about how do you deal with the osteo lesion? Are you more circumspect about what size, the diameter of the vessel? Because you're always worried about dissection in this area, and you may everything. Yeah.
Yeah. I'm not brave. Initially, I use a 6 millimeter balloon.
Yeah, I'm saying usually 5 or 6 approximately first, and then if like in this patient with a bigger size, then I would size up. Yeah.
Okay. How about Dr. Wang? Do you prefer sequential ballooning or one step to the diameter of you want?
Yeah, I agree. I once we should do is to check the location of IVUS, whether the wire is in the true lumen or false lumen, and all wires is located in the true lumen. I think maybe DCDB first is the first treatment strategy.
Okay. How about Dr. Wu and Dr. Li? What's your opinion?
Yeah, my opinion is safe is the first the way to go home. So maybe stage or just less size first, and then progress to the muscle. Just like I said, no more oversizing, and just make the stent maybe the safe way to go home, not only for doctor, also for patient.
Yeah. How about you, Dr. Wu?
I will dilate with a 4 mini balloon first,
Okay.
and then check the angiogram again.
Yes. Okay. And angiography here we are. Seems to be a little bit dissect. It's a challenge for us to deal with. So, what's your suggestion, Soga Sensei?
Put the stand.
Okay.
Yeah, easy to choice. Yeah. To cover the ostial side. Yeah.
Would you just put a small short stent there, or to cover that lesion, or would you just cover the whole lesion with the stent?
Well, at least I cover the CTO side of the stent.
Okay.
Yeah,
Okay.
mandatory. The other side, yeah, no bad. Maybe to cover the stent or DCB, whichever is okay, I think.
Yes. Okay. We move to next step is to stenting. So, what will you do, Dr. Zhong, before you jump? Will you recheck IVUS or just selected the stent? And what stent you prefer?
DS Illuvia first, and we DCP the distal first, and DS later.
Yeah. So, how do you make a decision about the precise plasma landing zone? Will you change different direction or?
Yeah, more deep left oblique
Okay.
is very helpful to identify the orifice of this.
Yeah, Soga Sensei suggests deeply oblique to identify the ostium. More clear. Yeah. But the dissection seems to a little bit extend into the common femoral artery.
Yeah, a little bit.
Yeah.
To cover the dissection.
So
Yeah,
Soga
yeah,
Sensei
to
means
cover
just cover the inlet of dissection or cover all the dissection area.
Yeah. A little bit stent proximal, maybe cover the distal common femoral.
Yeah.
Yeah.
A little bit.
可能就7。
Okay, right now, Dr. 钟，我们将会先去给另外房间先演讲一下好了。So,
Okay.
Right now we move to a short talk by Dr. Zhang. Hanson, Dr. Zhang, we are back.
Okay.
Okay. Right now,
Okay.
Dr. Zhang will give us a short talk about the papillary aneurysm, surgical and or endovascular treatment. Please.
Thank you, Dr. Son, and I'm Dr. Zhang from Dalian Tzu Chi Hospital, and now I will have a short talk about popliteal artery aneurysm. Shall we do surgical or endovascular treatment? Yeah, next. Okay, let's see a case first. This is the 88-year-old gentleman who had hypertension and smoking for decades, but quit now. And he had acute onset left leg cold, numbness, and pain, and then visit our hospital. Next. And you can see the CT, the left side SFA from the ostium is occluded. And BTK vessel, we can see it. And you can see the right side, the SFA is occluded. Next. And there are bilateral popliteal artery aneurysm. And left side is totally occluded, and right side there are much mural thrombus. Next. And in this case, because this acute limb ischemia, so we did open thrombectomy first. Next. And after the open thrombectomy, the aneurysm, we do percussion and repair. And after that, the final angiogram C, the result is good, and the downflow vessel is good. Next. Yeah, and this is the CT after treatment. Left leg is okay, but we see there is also aneurysm at the right side. So right side, we decided to do endovascular treatment for this patient. Next. Yeah, so you can see that there is popliteal artery aneurysm, and the BTK vessels are good and patterned. Next. So because of the size discrepancy, so we put the inflow stent is 11 millimeter wire bond, and the outflow stent is 8 millimeter wire bond. And after stenting, you can see there's only trivial endoleak. Yeah, the stent position is good. Next. Yeah, so after the procedure, the CT scan shows the good result, but you can see that there are some mild mural thrombus in the wire bond. Next. And 6 months later, during follow-up, we find out that the ABI down at the right leg. But the patient just have mild claudication because this patient is 88 years old. So we decided to do nothing for this patient. Yeah. Okay, next. So according to the guideline, the SBS guideline in 2022. Next. The popliteal artery aneurysm is about account for 70% of all peripheral artery aneurysms, and 95% predominantly affect men. And if there is acute limb ischemia from the popliteal artery aneurysm, the early ventilation rate up to 14%. Next. And if we see a patient have popliteal artery aneurysm, we should survey contralateral popliteal artery and abdominal aorta, because there is very high possibility to have a contralateral popliteal artery aneurysm and abdominal aortic aneurysm. Next. And if we see a symptomatic popliteal artery aneurysm, what should we do? If the aneurysm less than 20 millimeter and there is no risk factor, we can just keep observation. Yeah, if more than 20 millimeter, we should do repair for this patient. And what's the risk factor? The risk factor, if the aneurysm less than 20 millimeter, but there are mural thrombus or poor distal runoff, or clinically we suspect there is embolization. Even the aneurysm is small, we should do repair for this patient. Next. So if we decide to keep observation, what should we do? We should monitor if there are any changes in symptoms and check the distal pulse and monitor the aneurysm by Doppler ultrasound, because there will be complication developed within 1 year, and in 5 years, it's nearly 70% develop complications. Next. Okay, so if we decided to repair the aneurysm, what kind of procedure should we do? If we choose open repair, it's superior long-term patency, but the wood complication and there will be longer hospital stay. And endovascular, the advantage is less invasive, but there will be more reintervention, especially when the patient have poor tibial runoff. Next. Okay, so if the patient have popliteal artery aneurysm with acute limb ischemia, what should we do? If the patient just have mild symptom or moderate acute limb ischemia, ROSCOR grade 1 or 2A, we can do thrombolysis or some pharmacomechanical thrombectomy, and to improve the runoff, and then we can prompt to popliteal artery annular repair, no matter open or bypass or endovascular. But if the patient have severe acute limb ischemia, so we should prompt to surgical endovascular repair immediately to save the limb. And if the patient has Rutherford grade 3, we should do amputation for the patient to avoid reperfusion and the kidney injury. Next. Okay, so next. Yeah, so after this procedure, we should keep survey this patient because there, especially in endovascular treatment, maybe we will need reintervention within first 2 years. Next. Okay, next. Okay, this is SVS guideline, and do we have new evidence? Yes. This year we have PARADE study. Next. Before that, there is only a small study, about 30 patients, 15 popliteal artery endovascular, and 15 open surgery. Next. And in this study, we just know endovascular has a shorter hospital stay and shorter operation time, but the outcome is unclear. Next. Now the PARADE study, there are more than 600 patients joined in this study. This is a multi-center study. Next. And in open repair group, there are 440 patients, and in endo group is 165 patients. And the open group is the patient is younger and more smoker, and in endo group there are more older patients. Next. And if the first 30-day result is quite the same. No matter mortality, MACE, or graft occlusion, or intervention, the short-term result is the same. But the open group, there are more longer hospital stay, and there are some permanent nerve injury. Although the number is small, in 440 patients, there are only 3 patients. The risk is only 0.7%, but it's notable risk. Next. At 5 years, if we see secondary patency and amputation-free survival, 2 groups are the same. Next. But in primary patency and freedom from reintervention, open group is much better than endo group. Next. And reintervention in open group, most patients just graft thrombosis, so we just do thrombectomy or thrombolysis. But in endo group, there may be endo leak and maybe stent thrombosis need to manage, or the patient should convert to bypass surgery. Next. And the survival, open group is better than endo group, but that's maybe because the open group, the patient is younger than the endo one. Next. So in this large-scale RCT, it's just answered that we confirm the endo group have shorter hospital stay, and the secondary patency in 5 years, 2 groups, no difference. But the 5-year primary patency, open group is much better, but there are a small number of nerve injury in open group, and the endo group have more reintervention. Next. So we should weigh the advantage and adverse to decide which treatment should we do next. So the popliteal artery aneurysm is less than 2 centimeters, and there is no risk factor. Conservative and keep monitoring is what we should do. If the aneurysm more than 2 centimeters, surgery or endo, we can choose. Next. If surgery, the primary patency is good, but you will have longer hospital stay and rare but real nerve injury risk. So it's better for a younger and more active patient. Next. And endovascular treatment, there are shorter hospital stay, the same secondary patency, but there are more interventions for thrombosis or endo leak. So endovascular treatment it should consider when the patient is old or the surgical risk is high. Next. Thank you.
Thank you, Dr. Chang. I'm Dr. Li Zhonglong. Because our chairman soon have an important meeting, had to rush to go back to Taipei, so I take over the following duty. And thanks for the Dr. Chen. And as we both the surgeon, and I like to do the take-home message that surgeon has a better outcome, but if I can choose, I also choose the endovascular treatment because it's much easier and benefit for patient because of the short-term hospitalized. And what's the opinion about it, Dr. Soga?
Well, thank you very much. It's very useful and educational. So I deeply understand the difference between the endovascular and the open surgery. Thank you very much. Okay.
And Professor Tan?
Yes, being a surgeon as well, I'd rather do an open repair with the traditional open repair, which is the art is being lost. But for the correct anatomy for popliteal aneurysms and for the smaller ones, I think that there's a good role for endovascular, especially if there's no discrepancy of the landing zones from proximal to distal. I think when you get the discrepancy, that's where you get your endo leaks and your reintervention rates are much higher. And especially for those older patients, probably more than 80, they're never such a fit patient. Those are the ones to go for endo. The younger ones, I think a person who can do a good open repair, I still said the fast of time is still the way forward.
Dr. Kim? Independent? Okay. Dr. Chen.
I think depend the patient condition. If the patient is very comorbidity, I think endovascular is suitable for her. If the patient is very young, I think surgical pneumorectomy or standing, I think is okay. So depend to the patient condition.
And Dr. Wong?
Sorry. Yeah, I also agree all the comment of the panelists. I depend on the patient characteristic because we do the endovascular therapy. Sometimes we will put the cover stent or Viabond across the popliteal joint. So sometimes we will consider the patient's daily activity. If we have to go to work or do some exercise, sometimes I think the surgical repair may be more suitable for those patients. Thank you.
Dr. Lee.
I'm Dr. Lee Mini, Dr. Zhang. I have one recommendation. First of all, I believe more than 3 centimeter will be the more suitable indication for high-risky patient. In such 80 years old patient, we should extending more larger, more symptomatic for the true indication to do something. The second thing is I'm curious about the acute limb ischemia management strategy under the circumstances of popliteal artery aneurysm, because the thrombectomy is not so easy. You do the CDT, you do the PMT, there will some residual murothrombosis around inside the popliteal artery aneurysm. So, Chief Zhang, can you tell me how do you deal with the acute limb ischemia with popliteal artery aneurysm?
Yes. And according to the guideline, it said that if there is mild to moderate ischemia and the tissue it looks not so quickly to be dead, so we still have time. You can do thrombolysis, you can do pharmacomechanical thrombectomy, and to make the round of vein, to open the round of vein. And then after that, you can do the definite treatment for the aneurysm. So it's the first step, just open the distal round off. The second step, do treatment to the aneurysm. But if it's severe ischemia, you don't have much time. You should treat the aneurysm and the distal round off at the same time, no matter endovascular or surgical treatment.
Thank you, Dr. Chen. And last, do you have any suggestion? Because the guideline may be very important, but in the real life, what will you choose in such a old age female and such many comorbidity? And if you do it again, will you choose open or endo?
Yes, because in emergent situation, I will choose open because I'm the surgeon. For me, it's the quickest way to open the distal vessel and treat this problem. And even the patient is high risk, but for popliteal artery aneurysm, we can do just spinal anesthesia, and then we can treat this problem. Yeah, the patient don't have to do general anesthesia. So I think the surgical risk could be decreased.
Okay, thank you, Dr. Chen, and appreciate your speech. Now we must move back to the room 1, the angio room, because the stand had finished, and can move back to the angio room, and so can you show the final angio and the iris and after the standing?
Okay. Okay. And okay. We put the stent in the proximal SF including 还是 IVUS 啊。We see IVUS first. Yeah, IVUS first.
Okay. So can everyone see the IVUS on the screen? This is post DCB and the stenting. The IVUS is put back from the distal SFA. And we can see some dissection here around the involve the media area here. This is DCB side. And then put back from we can see this is the stenting area.
Professor
And then
Soga,
come
do
back
you have
here.
any opinion about the IVUS result?
And then here is dissection. Dissection retrograde involve the CFA. Here.
Okay.
And I think this is the 6 o'clock. This is DFA come into the CFA here. So maybe there's a little bit not covering the stem by the SFA inlet.
Could you show us the angio?
And then the CFA size here.
Excuse me, can you show the angiography, the final angiography?
Angel.
Can you put the angel?
We put a stem in the proximal by Illuvia 7 by 150 and the land BCB in the distal FA to T1 and to perform the hemostasis. And the land posterior by 6 high pressure balloon later. And the angiogram, you can see the ostium seams have a dissection thread. So I have no idea. Do I need additional stent or stay here?
Well, actually, I need one more stand for the proximal.
Use for proximal.
Yeah. Inflow is a very important, I think. Yeah, so there is a for short Illuvia stand. It seems to be.
Yeah, short Illuvia stent. Okay.
Yeah.
This was what I was mentioning
Say
earlier,
7
that
frame-
it's
7
inevitable to
millimeter.
be partially covering the
think
femoral
about
funder because the stump
Yeah,
is
7.
non-existent.
Exactly. What kind of stent are you going to put up? What kind of stent are you going to place? A balloon mountable stent or a self-expanding? For accuracy, you probably need a balloon mountable stent there, don't you? Because you really don't want to cover that up. Because you really can't help to deal with the origin of the profunda.
But how comfortable are you placing a balloon expandable stent in a joint where it can get crushed? Or
Not very, but you don't want to cover that profunda.
Oh.
Yeah, I'd prefer self-expanding.
Yeah, I have some concern about the deforming of the balloon
Yeah.
expander stand. Therefore, if I treat this region, I put the self-expandable. Yeah.
7最短的。7就是。
I think with this
That
one, we have,
section
to,
looks pretty bad, actually.
we have to come up at least
Yeah,
5
put a
millimeters, I
tissue
think,
to cover
which is
the-
going to cover, let's say, quite a lot of the profunda, I think.
Is it worth putting a wire into profunda first or a little balloon just to hold that so that you know you're not going to go too much?
It's a difficult case, I think.
Because we only have 7 millimeter BS. So I think if we put the 7, might have blown.
I think additional
into the
stain is needed
femur.
because very near the orifice. The SFS is most important. Keep the pattern.
Just for the mind of comfort, let's say there is a paper from Korea where they retrospectively reviewed patients where they covered the deep profunda not intentionally, but they just actually the patency of the profunda was preserved. So it's maybe the flow is directed through the struts. So it's not like the veins where it's always jailed. So, you know, I mean, we don't want it. It's not ideal, but if we get a situation like that, you know, I'm sure you have many patients you follow them and it's fine. So.
Yeah. Yeah, the stent extract impede the advance of the additional stent. So we need to advance my sheath, enter the stent first and deploy later. So maybe I need to deploy it on the down pulse.
And Professor Tan suggests, can you move the C-arm to 45 degree?
I think you should put the C-arm a bit more lateral to open up profunda origin, basically, to have a good look at it and mag it up even more.
Yep. 等我一下。Actually, might be the biggest angle is in the machine. It's not sealing frontal, so I think the maximum angle is 36.
Is it possible to get something like a 50 degrees or 60 degrees angulation? I think that'd be better to see the orifice.
Okay. Okay. 60. It does. It's 60. Yeah. Deep breath. Okay. Take deep breath. Okay. Let me try. Yes, we use the short parade stick first, and then deploy stent later. Thank you. Roll it first. Okay. Yeah.
Dr. Zong, how long of this stent? It seems to be much longer.
Yeah, because now we only have the shortest 80 millimeter.
80. Okay.
80.
Uh,
Yeah. If I was USB.
Okay, okay. You don't have the short one today. Mm.
Does everyone think it's okay? This location? Or
Goose
higher?
angle a bit, do you think?
Pardon?
Dr. King, is this a good position for the stand?
I think I want to stand a little bit further down. It's a little too high for my, in my opinion. But what about Dr. Soka?
Soka?
Yeah, I think so. A little bit going down. Maybe
just half.
5 millimeter.
So I'm halfway between now and the previous stand, I think.
Oh, no, but yeah, the actual difficult. Yeah.
Maybe it might be here.
Dr. John, you can do yourself and go ahead for this case.
It's okay. The initial dimple might be here.
Yeah.
So I think the dimple here is.
A little bit.
Yeah, open.
Okay, it's a
Okay.
It's
Just a little bit shortening.
Flower light.
It's okay. Okay.
Yeah.
Dr. Zong.
It's okay.
Oh, yeah, perfect.
Yeah. Yeah, thank you, Dr. Soka.
Okay, let's check the iris and time is limited. Sorry, Dr. Zong. Let's check the iris and please show us the angel.
Check iris.
After that, we'd like to wrap up this session.
Actually, 14的吧，对对的。对对的，可以。Iris。先看微小化，再。We just check the orifice. Okay, let me start from here. We do 2 layers inside. Yeah, here. And enter. And
Is it looking good?
Looks nice. Dr. Zong, looks nice.
Yeah, that's better. Yeah.
Yeah, to cover the whole direction.
All right.
Yeah, let's check the angel. Show us the angel. Yeah.
给我们看 Angel。
Looks nice. So good.
Yeah. Congratulations, Dr. Chen. And thank you for your special case and very impressed. And because of the time, we need to close this section. And then thank you for Soka, Kim, and Tan, and any penalties. Thank you for this. We must close this session. Thank you.